That's and then moving on.
Yeah, a little bit of gout and stuff, and then we'll go from there.
Really?
Okay, we're good. So I came here and I didn't have my ID with me. So the guy's like, "What do you want me to do?" I'm like, "I don't know. What happens when people don't bring their ID?" And he's looking at me. He's like, "That's never happened." I'm like, "You gotta be kidding me. You mean tell me 2,000, 3,000 people that come here every morning, not everybody brings their ID with them?" So I gave him one of my other, I had my global entry, and he's like, "What is this?" I'm like, "It's global entry. Let me in." He's cool about it. All right, let's get started. So last time we spoke about osteoarthritis and rheumatoid arthritis. We said what was the difference between one and the other, and we've kind of really narrowed in on the characteristics from one to the other because I guarantee it's going to be on your board. You will not, you will not get through your boards. I guarantee you're probably going to have at least 5 or 10 questions on osteoarthritis and rheumatoid arthritis. Probably have like 1 or 2 on osteoporosis because you constantly see this. This is a disease that we tend to see and it's never going away. Even though we supplement people the way we should, have them eat the right way, but the underlying problem always exists. And you guys will see it. You probably have family members that you see as they age, they start to change. And what I mean by that is this, they change as far as their height goes. I see it myself. My mom's starting to get to that age where it's crazy. I was there, I guess the day before yesterday, and I noticed it. She got up, she was in the kitchen, she was walking, and I'm looking, I'm like, wow, like her height is starting to change. So you'll constantly see this stuff, not just in your family members, but in your patients. But once again, this is one of those silent diseases that we tend to see, and it's out there. And it's only getting worse. And I'll explain that much more in detail. Well, maybe not so worse. And we'll explain why it's not so worse. So, what is osteoporosis? Well, we have, well, I think there's another slide before that, right? Okay. So let's talk about some facts. We know that osteoporosis exists. We see it mostly in postmenopausal patients, mostly females. Approximately 10 million Americans have osteoporosis, but that's not even the problem. The problem is it's going to get worse as we move along. And what I mean by that is this. There's roughly around 34 million people, or maybe even more now, it's only 3 times more, that have something called osteopenia. And what that is a precursor to osteoporosis. Okay, so if we were seeing the problem now, you're going to see the problem getting even worse. Now the question is, well, why? If we're educating patients, why would it get worse? Well, a lot of things are starting to happen. You might not even see it, and it's out there, it's readily available out there. And I'll kind of explain. You might think that the world is a safer place, right? And everything that we're doing, it helps us contribute to the next level of medicine. But we're finding that a lot of things are changing. Years ago, there was a group of, I guess, guys that used to work for the CDC and so forth, and they really took down the tobacco companies. And what they did was they woke up and they said, you know what? What's really hurting our healthcare is tobacco. These tobacco companies are making their products worse. The nicotine is there, and it's really exposed. And they actually went in there and exposed the whole thing. And then cigarette prices started to go up. I remember when I was younger, I used to live in Queens. I was born in Queens, and I would literally get 65 cents or 75 cents. I remember it was 3 quarters. I remember like it was yesterday. I would walk to the store and I would go ahead and get my dad cigarettes, Marlboro cigarettes, red, and I would give the guy 3 quarters. And he would say, well, that's enough for you to go get some candy also. And I would get bazooka gum because it was 5 cents back then, and cigarette packs were 65 cents. Nowadays, I don't know how much they are, but I was told they're roughly over $10 a pack, or maybe more, or maybe less, somewhere around there. But thing was, everything was exposed, and we saw how crazy people were addicted to cigarettes. Now the biggest thing that's starting to come out is, which is very, very, they're saying that it's probably 50 times worse than cigarettes. And you might say, well, what is 50 times worse than cigarettes that we're having here that's going to make our population in the worst manner? Well, it's sugar. You have no clue how much sugar you guys are eating, or we're all eating, in the things that we eat. I was in Turkey about a few months ago, and this happens all the time. I sat down and we're eating, and in all the European countries, it's much different than it is here. I remember I said, "Can I get an iced tea?" and the guy brings out a Lipton iced tea. You know, like those cans of Lipton iced tea, ice and cold, and I drink it, and all of a sudden it hits me. I'm like, wow, it tastes different. I'm like, well, in Europe, of course it's gonna taste different. Why wouldn't it? I looked at the contents of the can, and it had about 8 grams of sugar in it. That's all it did. And then when I flew home, I looked at the Lipton cans that we have at home and my kids drink, and it's like 48 grams of sugar, or 38 grams, or whatever it is. And then I happened to look at a Pepsi can, it's like 64 grams of sugar. And here, what I'm trying to tell you is, it's so different. It's not regulated. Here, it seems like nobody cares. And they're saying that silent killer is 50 times worse than tobacco was because people are ingesting more sugar than they ever have. Okay? Same concept here as we move along. You'll see what I'm talking about. So, when patients have osteoporosis, we find that nearly 50% of these are women, especially at the age of 50 or above. And simple reason for that is what? Hormonal changes and things of that age. So, what is actually happening here? Bone is constantly getting remodeled. And what I mean by that is this: while you're sitting here, your bones are getting shaved down and new bones are getting put in. And this is a constant balance that's supposed to be in place. And as that constant balance happens, you seem to be good to go. So what we do know is osteoclasts, they help break bone down. Osteoblasts help build new healthy bones. And that's happening as you're sitting down right now. Therefore, your bones are very strong. They're not susceptible to fractures. And that's what we want. You want the bone to get broken down and new bone to form. And that contributes to good bone, healthy bones. The problem comes into place is when this balance that you see here gets disrupted. And why does it get? Well, what happens is this: sometimes, well, in this case for osteoporosis, too much bone is being pulled off. Meaning, you just have your normal bone being pulled off. But then the bone formation, meaning the new bone that's starting to come in there, it's starting to slow down. And when that happens, we get something that looks like this. This is a normal, healthy bone under a microscope, and this is a bone that is not so healthy. It's much fragile. It's not being built here, meaning the bone density is not strong enough. There's a lot of holes at the level that we need it to be. And therefore, this is much more fragile than this. This can break if you put enough stress on it. This one, you just need a tiny amount of stress, and that bone will collapse. So, is there an infection? Is there a bacterial agent? Is there something that's causing it? No. Once again, back to what we were saying, risk factors. And on the exams, these risk factors are key. You have to understand that. Well, one of the biggest risk factors is female, in the sense that hormonal changes, which we all know. Certain ages, and then most importantly, your weight, your BMI. If you're less than 127 pounds, then there's a good chance that you can have strong or fast osteoporosis than somebody who wouldn't. Now you're probably saying to yourself, "What do you mean? When I look at it, my BMI seems to be normal. I'm just shorter. Therefore, just because I'm under 127 pounds, does that automatically make me in a state of osteopenia, osteoporosis? No. What we're trying to tell you is this: if you're 6'5", 6'8", 6'10", and you have a BMI or your weight is less than 127 pounds, that's a problem. If you are 5'1", 5'2", that's different. If you're 5'8", and all of a sudden you're not getting enough calcium, getting all your vitamins and so forth, if you're underweight, you're malnutrition, then that will happen. Keep that in mind. Cigarette smoking, being inactive, and then the secondary reasons are key. Because nowadays we know not to smoke. You open up TikTok and everybody's out there working, jogging, and so forth, so you're not really inactive. You're trying to eat right because there's enough educational material out there to say, hey, If you eat right, you stay healthy, drink a lot of water, and take care of your body, then you should avoid this. You shouldn't have any problems being in an osteopenic state. Then what is the reason? Why are we still going towards that direction? Well, we're finding now that the medications that you're currently on are putting you into an osteopenic stage or eventually turning into osteoporosis, meaning medications like methotrexate. Well, we're going to stop using methotrexate over time because we discussed that last time in class. But how many patients are on heparin? How many patients are on steroids? How many times have you gone out to your primary care physician and they've said to you, oh, you have enough respiratory infection. Let me give you a Z-Pack and give you some what? Give you some steroids. Let me give you a little prednisone, help you open you up. That you constantly see. It's more readily available. How many people do you know here, your family members, that are on Synthroid? Nowadays, everybody's on Synthroid because everybody has some kind of thyroid issue. Okay? Now I'll give you a perfect example. As a PA, we do all kinds of work. And the medical directors and so forth, we have a school district not too far from here called Garden City High School, Garden City School District. And every school district is very, very weird. You go to certain school districts and you find that kids have a lot of leukemia. You go to certain school districts and you find that a lot of kids have asthma problems and so forth. You go to other school districts, weird things are going on. I went to Garden City School District and been there for a couple of days doing some physicals on some students. Everybody's on Synthroid. It's weird. You see these little clusters all over the island. I can tell you all this stuff. I'm actually would love to do like a study for the island and figure out. The only reason why I'm able to do that is because we have school districts all over Long Island. And our medical directors kind of take care of the school district. So when you're at these school districts, you see kids that are on weird things and they can't communicate with other school districts because there's a HIPAA violation. That data cannot be shared. But you'd be surprised at crazy stuff that I see. It's really, really weird. All right. So what are the real reasons for osteoporosis? Well, nowadays, we're finding out that it's certain medications. And these are just some of the medications I can put on there. There's a lot more than that. Okay, so you see a kid that's on Synthroid, and you're like, what's going on here? Well, he has no clue that eventually this is in middle school and high school. They're taking Synthroid, but they don't know. They've never been educated that hey, this can cause osteoporosis. Other things, if that's not it, alcohol use is big here in the States. It's actually big everywhere. So therefore, patients who drink alcohol constantly getting hydrated, dehydrated, and so forth, push you in an osteopenic state. And then all the other stuff, low vitamin intake and things of that nature, that will do it. Much of this is starting to kind of, when I was growing up, I still remember drinking orange juice, and orange juice just tasted like shit. Excuse my language. It was like sometimes bitter. Like every once in a while, you get a good batch. But nowadays, orange juice just tastes like great. Like, oh, it's orange juice. Apple juice just tastes like apple juice because there's a lot of ingredients put in. And nowadays, if you look at some of the juices that you drink, it says what? It's fortified with calcium. It's fortified with vitamins and so forth. Back in the days, it didn't do that. Okay? So nowadays, if you drink your average drinks over the counter, much of the stuff is taken care of. And then other things like hyperparathyroidism and estrogen deficiency, which we already spoke about, and things of that nature. Now the question comes into place is, well, why hyperparathyroidism? Well, there's a small slide on this because it's on the boards. And it's very simple. When you have a parathyroid gland that's overactive, guess what it does? It makes too much parathyroid hormone. If you have too much parathyroid hormone that's circulating around, what's going to do is it's going to ask the bones to release the calcium that's within the bones. That calcium that normally sits in the bones, now all of a sudden, it's out of the bones. If it's outside the bones, then guess what? We have a problem. Those bones start to become brittle because the calcium that's supposed to be in the bones is no longer in the bones, and therefore you start falling into an osteopenic state. Now, how often does that happen? Not so much. But we do tend to see you going in there for thyroid surgery, having neck surgery, and so forth, and accidentally mix the parathyroid gland. When that happens, that's when things kind of go out of place. How often? Not so much, but it is one of the risk factors that are out there. All right. Now that we know what's happening at a cellular level with the osteoblast and osteoclast, we know the risk factors that are involved, and then most importantly, what's happening here in the States, the epidemiology. Now the question comes into place is, well, what do you see? Well, these patients will come in and they'll might not even complain of anything. There is no complaint. Patient will come in and say, I'm perfectly fine. You can't just be like, yeah, I think you have osteoporosis. How can you tell? Well, in primary care, the first thing that you do when you go to your primary care doctor is what? They do vitals on you. They check your height and they check your weight. That's one of the most important things. And the minute your height starts to change, red flags are going up. And then all these risk factors have to be put into place. Well, what's actually happening? Well, we have the vitals. Now the patient's going to go inside the room and we're going to do a physical examination on the patient. When the physical examination is done, sometimes these patients will start complaining of, well, my back hurts. To be honest with you, I spoke to my mom the other day. I'm like, how are you feeling? I didn't tell her she's starting to lose height, but I can see it. I said, how are you feeling? Oh, I have my aches and pains all in my body. I know you have, she has rheumatoid arthritis and so forth. But I'm like, how's your back? She's like, my back always hurts. You know that. Like, of course I do. Well, in my mind, I'm thinking, well, yeah, you're going to have back pain. The question is, why are you going to have back pain? Well, what we're starting to see is this little problem right here. Weight, gravity, these bones not being as strong, starting to look like this instead of this. Weight of the skull. Gravity would start causing small little compression fractures. And here's a perfect example. Here is one bone. Here is a smaller bone. Notice how this bone right here is much different than this bone. This bone looks like someone took it and put some compression on it. When you have that compression, it starts to fracture. And then this bone gets smaller. That's the exact reason why my mom is starting to lose her height. And as your patients, you'll see, they'll start losing their height also. Because on an x-ray, you'll start seeing these small little compression fractures. Someone who looks like this, over time, will start looking like this. Okay? Now, we keep on saying that it's a silent disease, and it is. Nobody's fallen. Nobody can see what's happening. It just slowly, over time, you start seeing some symptoms starting to set in. Now the question is, all right, well, what do we do? Mrs. Henry comes in and she's complaining of this pain, light little pain in my back, and I see already that her height is starting to change. And I bring her in. I said, how are you feeling? I have my joints and pains all over the back. My back also. No problem at all. So what I'm going to do is this. I'm going to go ahead and initiate some tests. Oh, here you go. A lot more tests. Yes, ma'am, I need to do more tests. All right, well, what do you need to do? I need to check to see if you have osteoporosis. Is there blood work? Yeah, there is. So what else do I have to do? I might have to do a scan on you. I don't want to do scans. Every time I do scans, I feel like there's too much radiation. I understand. Is there blood work? Because I don't mind getting stuck with a needle. Yes, there are blood work you do. Well, what do you suggest? Well, it's not what I suggest. It's what your insurance company will pay. Does that make sense? So the patient goes, what do you mean? What does the insurance company pay? Isn't it supposed to be all about me? No, it's not about you. Those days that we have to worry about what you think are gone. I know it sounds terrible, but that's true. So she says, tell me, what do you mean? All right, so first things first, we can do something called bone density testing. Mrs. Henry, that seems to be the safest way. It's a small little scan that we can do. It's very inexpensive. Your insurance company will pay for it, and it only takes a few minutes or so. Okay. Anything other options? Yes, there are other options. You remember you had said blood work? Well, there are options. And that option is something called bone turnover markers. What is that? Well, it's blood work. Oh, it's blood work? Yes, it's called trap enzymes. So it's just simple blood work. Yes, it is. Can I get a urine test out of it? Yeah. Because these enzymes will float around not only in your blood, but it'll also start floating around in your urine. Well, why can't we just do that? I'll just pee in a cup. Well, we could, but I first have to get the insurance company to approve it. All right, well, why don't you call the insurance company? I get on the phone with the insurance company, and now 2 days have gone by. That's how long it's going to take. The insurance company says, nah, we're not paying for it. Well, why? Because it's going to cost us $600 to do a blood work or a urine test to find these trap enzymes. We'd rather not pay for that. Because, hi, well, it costs like $700. What we'd rather pay for is this bone density testing. Well, all right. How much does that cost? $40. And we need to save some money. So therefore, the $40 test is approved, but not the $700 test. All right, you have a point there. Seems like it's a business, right? Because what you don't know is medicine is a business. The people who run this are non-doctors. So they make the list of what you can do, what you can't do. It's unfortunate, but it's better for you to see this now before you get out there. All right, so now the next question is, if the bone density test is approved, well, the insurance company said, wait a second, calm down. We still pay for the $40, but let's see if we really need to give you the $40 to get it done. Tell me this patient that you have, is this patient postmenopausal, and are they under the age of 65? And if they are under the age of 65, tell me how many risk factors that they have from the previous slide that you showed your students. We need to know how many, and then we'll determine if we're going to approve the $40 test. Or if the patient's above 65, patient's postmenopausal, then it's approved. Well, where'd you come up with those standards? Well, those standards were approved by the National Osteoporosis Foundation. So that's the guidelines we follow. Any questions? Do I have any options? No. That's our algorithm. Follow it, and that's how you get approved. Get the idea? All right, not a problem. So I go back to my patient. I tell my patient, listen, you're over the age of 65. You're postmenopausal, so it's already approved. Well, what's approved? My bone turnover markers? No. Just a bone density testing. All right, not a problem at all. So tell me, what do I do? Well, bone density testing is very simple. It looks like this, man. You put your foot in this and your heel in this little machine, and this will go ahead and let us know what your scores are. It simply shoots a beam from one end to the other end and lets us know how much penetration we can get through. Meaning, if your bone is very dense and there's no bone in there, the light should pass pretty through. But if there's a lot of bone in there, then it's going to have a hard time getting through. It kind of seems like it's mixed, right? That's what you tell your patient. If not, we can have you lay down here, and this little machine scans your whole body from top to bottom. Well, how long or how often do I have to get this done? Once a year, we're going to get it done. That's what your insurance will approve it. All right. Well, I can go ahead and do certain areas like the lumbar spine, your hips, and so forth. Your heels, fingers, forearm. These are all good areas to test from. Makes sense so far. What else? Are you sure that's the only other test that I could get done? Because I was home, I went to ChatGPT, and ChatGPT said otherwise. They said besides the bone turnover markers and the bone density testing, ChatGPT told me that there's other ways. Yes, there are other ways. Those other ways are ultrasounds. But I will tell you that they're very inexpensive, very less radiation, but they're not as good. They won't give you the best results. Well, I also saw that CT scans will work. Yes, CT scans are probably the best, but your insurance is not going to approve it. It costs way too much money. The insurance said that it'll cost like $900 to do, and they're not going to do it. And one of the reasons why they don't want to do it is because it has high radiation exposure. We're not going to do a CT scan on you every 6 months to a year because it's too much radiation. All right, I see what you're saying. So you're telling me there's about 4 ways of doing it: CT scans, ultrasounds, bone turnover markers, and then the bone density. And it seems like insurance will pay for the bone density testing because it's the least expensive and it's usually very, very good. All right, fair enough. Go ahead, do it. We do the test, and now all of a sudden the results are back. The question comes into place is, well, how do we go and interpret these results? There's T-scores and Z-scores. T-scores are mostly for normal patients. Z-scores are for someone who has secondary source of osteoporosis, like parahypothyroidism. But right now, we don't see too many of these. Let's concentrate on the T-scores. All right, not a problem at all. Tell me what my score is. Well, you're over the age of 65 and you have osteoporosis, so your T-score is less than negative 2.5. Somebody who's in osteopenic state is less than negative 1.0 up to here, and that's normal. And you're probably saying to yourself, who came up with these? Why can't they just do like 1 to 4 normal, 4 to 8 here, and then anything worse? It could have, but somebody sat down and made these fancy numbers, and that's what we have to stick to. When I recertified a couple of years ago, I've had this exact chart pop up where I hit the button on the question and this chart popped up. And I was able to figure out the patient had osteoporosis. And at that point, the patient was in osteopenic state. So I would suggest that you know these numbers because they will be on your boards. All right, now that we've diagnosed this patient with osteoporosis, the next question comes into place is, how do you treat this patient? Well, treating them might be simple. So first things first, you want to make sure they have enough calcium, they have enough vitamin D intake. You want to ask Mrs. Henry, listen, you have to start doing some exercises. I want you to stay active. Get out there, start walking around. And you know that drink that you have every night, well, maybe kind of reduce it a little. And if you are smoking, stop smoking. Well, I don't smoke, but every time I go on Wednesdays, I play poker with my friends and they're all smoking in there. Well, maybe you shouldn't play poker. Get the idea? These are the precursors. The risk factors are key here. That's what the question is going to ask you on the risk factors. So how do we treat this patient? Well, obviously vitamin D, vitamin C, and so forth. But insurance companies are going to push you to do other things. If you haven't heard about them, now is the time to learn about them. They're called MIPS, M-I-P-S, MIPS protocols. They're not going to be on your boards. They're not going to be on my exam, but you should know them because that will guide you how you're going to practice medicine nowadays. In primary care, outpatient, inpatient, wherever you go, you will have to worry about something called MIPS. They're incentivized programs that are set by the insurance companies. And what they want you to do is this. If they know a patient's over the age of 65, they know the patient's postmenopausal, they know the patient has osteoporosis, you've done a DEXA scan on them, and obviously the scores have indicated the patient has osteoporosis. They will mandate you to say, okay, besides educating them on proper diet and everything else, we want you to start doing some other things. And if you don't document it, guess what's going to happen? Your office, the hospital, wherever it might be, will not get reimbursed. Every year, they watch what you do through EMR nowadays. They pull your notes. And if you're not doing it, then they won't incentivize you or they won't pay you as much as you should be getting paid on a claim that you put in. So that question is, well, what do you do? What are these MIPS protocols? They want you to go and address this. You want you to check to see if the patient is osteoporotic. 4 precautions. Did you check the patient's fall precautions? Did you check a balance study on the patient to see how well their balance is? Did you check to see if they wear glasses, if they don't wear glasses? How often does a patient, an elderly patient, go to the optometrist to get eyes checked? Not so often. Now, why is this important? Can anyone tell me? Nobody cares. I'm just going to put the hell out of here. All right. Fall. Somebody falls, they're elderly, what happens? They break what? Hip. Now, what you don't know is statistics that shows us that if you break a hip, everything declines from there. And it's documented and it is guaranteed. You break a hip, your life expectancy starts to decline because most elderly patients live alone nowadays. And when they fall, they break the hip, the first thing that they do is, oh my God, my daughter, my son has to leave their job and come and take care of me and blah, blah, blah. And it's a whole thing to do. And then once it's done, the patient's back at home after that surgery, they say, you know what, it's probably best for me to not what? Maybe it's not for me best to just get up. I'm just going to relax here because every time I get up, I fall. And when I fall, caused all problems for my family and everything. So I'm just going to sit here. And they start becoming inactive and start getting bed sores and all kinds of stuff happens. And patients start declining. It is documented that happens. So therefore, the insurance companies are going to want you to put this in. Somebody who has hypertension, you must have them go see what? Cardiologist. Also what? Eye doctor, right? Somebody who has diabetes has to go see who? Who? Dietitian. Who else? Get the idea? 15 years ago, 10 years ago, never heard of it. Now it's mandated. And if you don't, it simply does this. This is the way it's done. Let's say if you work in a primary care office, you're one of the PAs at the office. And now you're saying, you know what? I'm seeing the patient. At the end of the year, every 6 months, I start pulling your notes and start seeing what's happening. Trauma versus the emergency room. Trauma versus the emergency room. You would think to find a better person with a clearer voice. Okay. So if you don't, they pull your chart and they see, hey, this PA is documented. The patient did not go to an eye doctor, did not go to a podiatrist. You know what they do? They wait a year and they say, listen, you're not doing your job. Therefore, all our patients that have United Healthcare now, we're not going to send them to you. And every time you go and file a claim with us, we're not going to pay you. We're going to actually mandate the patient to get up and go down to the doctor that's around the corner from you because he or she is doing what they're supposed to do. You get the idea? Now, as much as you're like, oh, my uncle's a doctor, oh, my mom's a doctor. Everybody thinks that doctors and healthcare practitioners are doing. Okay. So you can easily lose your job in the sense that you would think doctors are in a position where they can go ahead and kind of demand what they want. If the insurance company stops paying you, you're done. You're out of a job. You could be a doctor, you could be wherever. And even the hospitals won't hire you because you have to get credentials with the insurance company. So if United Healthcare decides that, hey, you know what? You're a terrible doctor or you're a terrible PA. You're not doing what you're supposed to do with all the MIF protocols. Then guess what? We'll just pull you off the panel. You get pulled off the panel, and you're done. And every time you get credentialed, which you don't even know, there's a website called CAQH, where all your credentialing has to go in there. And if it says United Healthcare has dropped you because you're a terrible practitioner, guess what? No one's going to hire you because they can't use you then. Does that make sense? You guys will probably never hear this, but you should hear this because it's a big part of medicine. And I see some of you guys don't even care. You guys like, I think TikTok is back there and stuff like that. All right, let's move along. Osteoporosis. So the question comes into place is, one of the biggest things is vitamins and vitamin D and calcium and so forth. And this is very important. Between the ages of 9 and 18, you're not eating well as you should. Therefore, you should be getting about 1,300 milligrams of calcium and so forth. By the time you hit 19 to 50, you're starting to eat right. You're eating enough food and so forth. You're more aware of what you're eating. Therefore, levels come down. When you get older, you start getting picky again. And then you're going to have to start going back up again to 1,200. This has to be the average dosages. Now, if you start taking 1,300 milligrams of, calcium in one morning, your body's only going to absorb so much of it. You'll pee the rest out. You'll never get 1,300 milligrams getting absorbed at one time. That's what they don't tell you. Vitamins are good, but vitamins are useless if you take them all at one time. Vitamins should be broken up. You should be taking some in the morning, some in the evening. So if your body's only absorbing, 800, then the rest of it's going to get peed out. Therefore, if you can take this and break it down, have 800 in the morning and 800 in the evening, you'll get better absorption. And that's the way it's really proven, how vitamins really work. Alongside with that, vitamin D, you should take at least 600 to 800 units daily. And once again, you should divide those for better absorption. That's what they don't tell you. They just pack it all in there. Okay? All right. So, other treatments, just keep in mind. The Z-scores have to match up in order for you to go treat those patients for secondary. If you have hyperparathyroidism and so forth, any kind of malignancy, kidney disease and so forth, then the Z-scores is what you need to work up. All right, so how do you treat these patients? Well, obviously, vitamins, as we mentioned before, hormone replacement therapy, very, very key here. This is very big nowadays. It is FDA approved, and it works, especially for postmenopausal females and so forth, but has a lot of risk factors. hormone replacement therapy is key nowadays. And I think there were some big studies that were done in the last month or two, and they're saying that the benefits of this outweighs the benefits of this. Some people say absolutely not. Getting the risk of DVTs, coronary artery disease, and most importantly, stroke, and the chance of breast cancer going up. I don't want to take this medication. A lot of people say that. But the new studies have showed that this much outweighs this. The chance of you getting these are much, much lower. Therefore, hormone replacement therapy is very, very important. And now you'll see that a lot of females, when women's health, everybody wants hormone replacement therapy nowadays. Everybody wants hormone replacement therapy because it seems to work. In the past, females would shy away from this, but now I'm telling you that's where it is. If you want to make a lot of money, when you get out here, everybody's like, okay. If you want to make a lot of money, if you're a female, you should absolutely go into women's health. And you should do GLPs, give everybody injections and so forth, and do hormone replacement therapy because it really does work. And I'm not saying that it works in the sense that patients actually feel good. And I don't mean it. Okay. I have a med spa. We had it for like 8 years and so forth. And for females, the lasers, Botox, that's all bullshit, honestly. Lasers don't work. We have hundreds and thousands of lasers. Some of them work, most of them don't work. It's not going to take away the ugliness. I honestly, it never takes away. Botox only works for a little bit until you're like, all right, how much Botox can I get in my face? Okay. You want to know what makes people feel better? Is deep inside. You got to change their mentality. And GLPs, they really do work. We don't have enough evidence on them right now, but right now, it's great. Before 9:30, before 9 o'clock, women are lined up out the door to get their injections. And they're losing weight, and then as they're losing weight, their motivation kicks in, and they're all in hormone replacement therapy. All right, other medications, estrogen receptors or modulators. There's another form of medication like Avista and so forth. They are also approved by the FDA, especially for postmenopausal females that have osteoporosis. And once again, just be very careful. It also increases the risk of DVTs and most importantly, hot flashes. When this medication first came around, I remember I was working in the emergency room, and you would have a lot of patients that would come in complaining of hot flashes. They weren't sure what hot flashes were. It really was like abnormal symptoms for them, and they thought they were having heart attacks and so forth. And we found out that it was just a side effect of the medications. So if you decide that you want to put somebody on a Vista, you have to let them know about the hot flashes. Very, very, very important. Okay. Other medications, calcitonin. These are also FDA approved for osteoporosis. These are slightly different. Subcutaneous injections, IM injections, and most importantly, intranasal. Very I guess popular ones are the intranasal one that you shoot up your nose. Okay. And they work. And the reason why these work very well is because they really, really concentrate on the spine itself. So they've been shown, and the data indicates that it decreases new fractures within the spinal column. Okay, that's the reason why, if that's the underlying issue, these patients will get started on calcitonin. Last but not least, biophosphonates, another line of treatment for patients of osteoporosis. They work, and they work very, very well. Medications like Fosamax, Actonel that you tend to see. And what they do is they increase bone density also in the spinal column. And they work very, very well. Okay. They reduce osteoclast activity. So that's the area where they really, really work well. Okay. Just be very careful with these medications. It causes dysphagia. So if you decide to give these medications to a patient, please, please, please make sure that they don't eat anything for a solid hour, because that will cause them to have aspiration pneumonia. Okay. And other things for biophosphonates, they're contraindicated with anybody who has any kind of renal disease. Okay. So please keep that in mind because they work in the kidneys. Okay. So if you have any kind of AKI, chronic kidney disease, these medications are not for those patients at all. Last but not least, recombinant parathyroid hormones. These pretty much work by stimulating the osteoblast activity. Okay, so keep that in mind. They actually go in there and put more bone that your body would normally do. So more bone when the bone or the density within the bone is not strong enough, these will go in there and put more bone on there. Now, it's very common. If there's not enough bone on there, then it will do its job. But if you already have underlying problems, right? then you have to be careful, like Paget's disease. If you have any kind of congenital issues that you already have abnormal bone growth to begin with, then that abnormal bone growth will be a common denominator. And then on top of that, if you start adding more bone on, the bone's going to get completely unstable. And you might say, what do you mean by that? When we start talking about gout in a few minutes, you will see exactly what I'm talking about when I have you look at an x-ray. A bone should be nice and clean. If you keep on adding more bone on top of bone that's not stable to begin with at the base level, then the whole structure collapses. It's the same concept. If you don't have a strong foundation, you keep on putting junk on top of it, that foundation will crack underneath. Same concept goes here, okay? The only problems with this is leg cramping, dizziness, nausea, okay? Keep that in mind. And that's it. Why don't we take a 5-minute break? You guys get up, move around a little, and we'll start talking about gout and stuff. Yes.
Question.
Sure.
Like, if you were to give, like,
Stop calling professor. Just say that.
okay. Like, do you realistically give a patient, like a woman that has osteoporosis, like, and you were to tell her, like start going to the gym, can you start like creatine, and then like that would also like for
Absolutely. So creatine is a great substance. And now, you see a lot of these TikTok and social media saying that it's great for the brain. But you know what I'm starting to say? So as I told you before, we have a med spa, and we have a lot of females that come to the med spa for female wellness. But we also have a lot of men that come in for testosterone therapy and peptides and so forth. And one of the biggest things that they do is when they come in, they're uploading on creatine, which is fine. But what they're not showing is when you do blood work, it really hits the kidneys really hard. Their BU and creatinine levels starting to go up because they're ingesting too much creatine. They're saying, oh, it's great from the brain, it's great. That's what social media is saying. But it really puts a strain on the kidneys itself. You can do that, but you have to check their blood work and make sure the kidneys are functioning well as they should. As somebody who's in their 60s, you have to understand that the kidneys are not functioning as well as they always do when they were younger. So that's completely okay, but you got to check the kidney functions. Go to it.
You told us last semester that you had somebody that went in. It was a kid, right?
Yeah.
And he like took too much of it.
Too much of it. Yeah.
He only could take 5 grams.
So a lot of the studies are showing that 5, 10, 15 grams, even 20 grams is okay for you to take. The problem is they're taking it all in one shot.
Yeah, exactly.
And then putting it straight in the kidneys.
Yeah.
You can take creatine, but you do 7 to 10 in the morning, 7 to 10 in the evening, it takes the weight off the kidneys.
I see. Yeah, okay.
And then you don't see that problem. The kidneys take a little bit of heat, they clean themselves out. But stacking all that stuff on top really is not working.
Yeah, that's why. Just like, yeah. Scared that she's gonna get and prepare. Like, doesn't know, like, before she.
Yeah, there are only 4 lectures for this, right?
5.
Oh, 5, okay. Yeah.
My grandma had like and then I really went to wrestle my mom. Yeah, I feel like try my lunch. I was like, oh, my grandma ended up yeah. And she fell again. I wish I went on there just like when she fell, and that was really hyperlining. And she got her up. Metal. You're like, yeah, the girls. Like that's so much time. Yeah, that's but like like get it there. Oh my god, I didn't. I think it's like different. It's I know it's like kind of like my turn.
It's like, and that's like good chance. That's real steroid heroin. It's actually viral. Yeah, it's like I don't think hospitals like even though you said it's not worse.
Yeah, I feel like that. I'm going
Like what if you're in for like that?
Oh, yeah. I don't know those people, but I know they think I'm not. You just put it on and it like
Oh yeah, my God, yeah. She had like really bad like get really cancer like brain like
yeah.
like bright red like not like I like
Well, it's like that one thing that you got. That's wrong. Like, you know, like when I with treadmill.
yeah I think a lot of
Yeah, like I feel like I would say like if I put the process and like that's every single thing I've ever heard. That's like they have give me separate prescriptions. I never got it all at once.
I would try to get that every year.
No, you have to start like really like I mean, put on
I like try. Like this is like once
but now that's how it is. Yeah, yeah. You know,
I would want to use like
yeah, like I wanted to love my but I don't really.
I think that's weird on my like.
I don't want to. Also, like if I had it now, I yeah. I
All right, let's get going.
Wait, yeah. Right.
Thank you.
You're gonna forget everything.
All right. I'm sorry if I tell you these little side stories, but I think it puts everything in perspective as far as what we're talking about. I'm not trying to waste any of your time. I just think that certain things have to make sense, like MIPS and so forth, with what we're doing, because you guys are going to see this when you get out there. And there are no classes that tell you about MIPS and these protocols that are out there. I think they're very, very important practicing medicine nowadays. And it's not like you have an option, you're forced to do it. And if you don't do it, it can be a problem. Okay. So I think it is important. These little side things. All right, let's talk about the next thing. Gout. Obviously, a different type of neuropathy, meaning a diagnosis that has joint pain involved. So, what is gout? Gout is a completely different type of neuropathy in the sense that, I guess, the best way to kind of put it is, there's a foreign body over time starts to formulate between the joint lines, and this foreign body, after a while, if it builds up too much, is going to start causing some joint pain. Now, you should be asking, well, if that's so the case, what is a foreign body? And we've done so many of these slides. Are there risk factors? Is there any indication of what gets them to set into these places? And tell me about signs, symptoms, and treatment. Because I think that's pretty much what I need to know to answer any questions. When you guys start studying for your boards, that's key here. That's what you need to know. You need to know a little bit about the physiology of what's going on here, and then most importantly, signs and symptoms, And then since we so many signs and symptoms about everything, that once you start differentiating between one or the other, everything should be good to go. Now, I remember when I was in PA school, I'm gonna be honest with you, I wasn't good academically at all. I didn't have I just didn't have the desire to put all the work in and study, which was a big problem on my end. But I found a book, and I still remember it. I can't find it anywhere. When I was going to PA school, there was a book that was it was published by a third year or fourth year medical student. I forgot his. I know his last name was Lee. I don't remember his first name, but it was a book that was a long book, and he had a very different approach to how he put things together. And I got to tell you, it worked for me. And I used that book. It was fairly expensive, so I used to hide in Barnes and Nobles, like in the crafts section, because nobody would take it. I would just take it out every time I used it, and I highlighted it, did everything. I abused that book, and I just left it there. Shouldn't have been doing that, but I did. But what he did was he would categorize symptoms and what to look for the symptoms, and eventually you're able to figure out what the diagnosis was and figure out the exam question by how the patient presented. Like certain disease process, certain rashes are purple. They're on the trunk, and that's the only way they are. Certain rashes are just painful, and certain are not, and it will help you differentiate that. It was a good, like maybe 6 hour read, but I gotta tell you, it really, really, really helped. And I remember when I took the boards, it just made sense because the way he put everything into an algorithm, it just worked. And for me, who was a strong academic student, it was a home run for me, honestly. And if you can actually see how he put things together, because I'm a visual learner. But I hope that helps you. And that's the reason why I use these terms. There's a foreign body that's coming into the joint line. Okay. In the past, like osteoporosis, over time, the cartilage will wear away. This has nothing to do with the cartilage. Now the question comes into place is, well, what is a foreign body? And tell me what the signs and symptoms so I can figure out what the signs and symptoms are. Therefore, I can go ahead and answer the question that I need to. So what is gout? It is a neuropathy. It does cause arthritis over time, and it does cause inflammation. The inflammation causes the pain causes joint pain, and we're moving along. The question is, what is inserted within the joint lines? Well, it's actually something called monosodium urate crystals, or MSU crystals, that start forming within these joint spaces. How do you get them? Or overexposure of too much uric acid. That's what causes it. So, some epidemiology, very important to know, 90% of the people who get gout are men, and usually health happens within the 5th decade, by the time you're in your late 40s, early 50s. And this is important because back to the questions I was telling you, you are not going to get a case vignette where it's going to say a 35-year-old and it turns out to be gout, because it doesn't fall within that realm. That's how you figure out questions, and that's the reason why this is important. If you see a 35-year-old and you think it's gout, it's not gout. Very rarely will be gout. But if all of a sudden they say it's a 55-year-old, boom. That should help with helping solving that question. So 55-year-old comes in complaining of joint pain. We know that's primarily 90% of men, and it's rarely seen in females prior to menopause and so forth. Not so much of something you need to know, but everything else does make sense. So there are risk factors just like everything else. Risk factors are key. Obesity, that means you're just not eating right. You're inactive and you're just eating foods that you're not supposed to eat. Trauma will do it, just like I hit him in the elbow broke, the joint broke, and now all of a sudden you have too much uric acid in the body. That uric acid is going to go right to that area. Okay? Hyperlipidemia, your cholesterol is off because you're not eating well. And then there's a lot of other things. Chronic renal failure. You might say, why renal failure? Well, uric acid excretes out of your urine. Your kidneys should push everything out. If you have a problem with your kidneys are not pushing not pushing the uric acid out. Therefore, it's being held into your body, and then it starts going to the joint lines. So that would make sense. You get the idea? Now, you might say, diet, hyperlipidemia, obesity, all that stuff makes sense. Diabetes. What's in the diet that's causing this? Well, we find out that there are purine-rich diet, like sardines, anchovies. And you might say, well, I don't eat anchovies. When's the last time you ate an anchovy?
Never.
Sardines, anybody? Nothing? All right. We don't see that much over here. Sweet breads? Maybe. When was the last time you ate that stuff? This stuff is very popular in Europe. Patients who have gout tend to have it because of the sardines and anchovies. Has anyone ever had like a real Caesar salad here, like a real one? What's in a real Caesar salad? Anchovies, crushed up anchovies. And believe it or not, it is amazing. If you never had it, you should really try it one day, honestly. Anyhow, different point. Now, if that's happening here, nobody's eating sardines here, and sweet breads and anchovies, then what are you worried about? Well, here in the States, we have a different problem. And that different problem is alcohol. Alcohol, alcohol. We're constantly drinking alcohol, and when we drink alcohol, we get dehydrated. And when you get dehydrated, what's the next thing that you do when you wake up in the morning? You're drinking Gatorade, you're eating all that, hydrating yourself, and that will cause hydration, dehydration, and that will eventually lead to having gout. Now, you might say, all right, well, I don't see that too often. Have you ever gone down south? Down there, they make their own liquor, and it's called what? Moonshine. Okay? If you have never had it, you should try it. Okay? But if you drink enough of it, it's going to cause the same problem. It will excel the hydration dehydration cycle because that alcohol down south is much stronger. It's like drinking 150. Never mind. You get the idea. Okay, but keep that in mind. Okay, and then if that's not enough, saying, well, we don't drink. My cousin or my uncle, he never drinks. Well, my uncle, he never drank in his whole life. He doesn't eat sardines, and what could it be? Well, over time, medications seem to do it. Medications like what? Aspirin. Now, if I would ask you, hey, do you know a family member who's on aspirin? Half the class will raise their hand. That's a problem. I would ask how many of your patients or people you know are on diuretics. A lot of people are on diuretics nowadays, and that will do it. And you might say, what do you mean diuretics? Why would that? Well, think about it. Diuretics. What do? They dehydrate you. Simple concept. Okay, so keep that in mind. And then cyclosporins, you tend to be right on top of the list. But believe it or not, nowadays here in the States, it's alcohol use and then aspirin, diuretics, and there's a few other medications that are out there that will do it. Okay, so please keep that in mind. And that's how it sets in. That's the reason why a 30-year-old will not get this because their kidneys will function as well as they should. But as you get to an older stage, when you start hitting your 50s, everything kind of slows down. The medications and all that stuff on top of it will make things worse. Keep that in mind. All right, so what's actually happening here? Back to the bread and butter. You have too much uric acid in the body, and then there's too much overproduction. And then under excretion. Either you have a kidney problem that's not excreting it, or you're taking too much of it in. Okay? And that over time, when you have too much uric acid in the body, it starts depositing within the joints, and within those joints, it starts to cause inflammation. Now, when you start talking about gout, the type of crystals are very important. MSU crystals, monosodium crystal. Those are it. You might say, well, why do you keep on shouting that over and over again? Because the case vignettes that you will get, they will try to trick you with gout and something called pseudo gout. And therefore, you need to know the difference. In pseudo gout, we're talking about different types of crystals, but the signs and symptoms are the same. That's the reason why it's key here. In pseudo gout, we're talking about calcium crystals. So keep that in mind. Okay? Every time you pass a stone, the urologist or whoever is going to say, not a problem at all. I'm going to give you a strainer. When you pee, I want you to pee through it. And a small little stone might pop out. And that stone gets sent to the what? Pathologist, and they look at it and they say, oh, this is a MSU stone. So you have too much uric acid in the body. Oh, it's a calcium stone. Maybe you have pseudogout. You get the idea? It's just that simple. All right, so now that we know the pathophysiology, what we're looking for, what are the signs and symptoms? What is the case vignette going to ask you? You have a 58-year-old male who comes into your office. He's complaining of some joint pain. On a physical examination, you notice your olecranon bursa swollen. You see around his ear, a pinna is a nodule around his ear, right ear. Okay? He's complaining of some tenderness in the joints of his elbow. On a physical examination, not else is seen, but when looked over labs, his BUN creatinine is elevated. You see where I'm going with this? So you might say, well, I still don't understand what you're saying. What do you mean, pinna? This is what I mean. Okay? What do you mean? Get the idea? This is stuff that you're looking for, and I'll show you some other one. We'll talk about olecranon bursa in a few minutes. Okay? Patients usually have kidney problems. Here's what the ear looks like. What else? A different kind of case vignette. A 56-year-old male comes into your office complaining of pain in the foot. And this is what they always say. I don't know. I don't feel good. My foot hurts. I think last night when I was sleeping, I was bit by a spider, or I woke up and I hit my toe when I was going to the bathroom. I don't know, but I know it's swollen. That's usually the complaint that you'll get. None of those are true, because very rarely will you get bit by a spider sitting here unless you're in a third world country. And if you woke up at 2 o'clock in the morning to go to the bathroom, and if you stubbed your toe, you would know about it. I would wake up right away. Yes.
So it's sudden onset?
No, this is slowly over time, but it gets to the point where it becomes painful. Last week I was bit by a spider and so forth. Okay, so what you tend to start seeing is severe pain, swelling, and I have to be honest with you, about 85% to 90% of the exam questions that you'll get will be here. Here. 55-year-old male comes into your office complaining of first metatarsal phalange joint pain or podagar pain. Patient states that they were bit by a spider or whatever the case might be, or they don't know the mechanism of injury. And the toe looks like this. You're gonna be like, what? This is pretty bad. Well, all the pain's right there. So what I'm trying to say is majority of the questions for gout are going to talk about the great toe pain. This is what it looks like on the hands over time. This is a severe case. This is what an elbow looks like over time. And if you want to know what's underneath the elbow, it's this. It's a shiny substance. I always say it looks like mother of pearl. You ever have a watch that has a mother of pearl in it? Kind of looks like that, shines back at you. So, what do? Patients come in, complaining of joint pain, stuff going on in the ear, the elbows, their hands. Well, what we want to do is, we know the problem is uric acid that's too much in the body. Patient comes in complaining of pain in the toe. What we're going to do is we're not going to do anything at that point, in the sense that we're going to treat the patient and say, go home. When the symptoms are completely resolved, I want you to come back. When you come back, I will get a uric acid levels on you then. Well, why can't you just do it now, right here? Well, it's kind of like diabetes. It's kind of like your cholesterol. If you eat a Big Mac and come to me early in the morning, and I get blood work on you for your cholesterol, it's not going to be right, right? You just had a Big Mac. So, of course, it's going to be elevated. I want you to go home until everything is resolved and then come back. And when you come back, when you're at baseline, your uric acid levels will be already elevated. It's almost like fasting, but not. You're asymptomatic, and then when your uric acid levels are high, that will let us know that your uric acid levels are constantly elevated. And that will let us know if you have gout. Because all the clinical symptoms line up with elevated gout, elevated uric acid levels in the body. You can also get it through a urine. You can also get ESR, CRP markers, which are inflammatory markers, and that if all else fails and you still can't figure it out, you go ahead and cut open the elbow, scrape a little bit of that out, either from the finger or ears or whatever the case might be. The ears might be much easier. You take a little needle and you put it right into that pinna, into that little thing, and you aspirate a little bit of it out, and you send it to the lab. The pathologist will call you and says, oh, I see what you wrote, constant uric acid levels, patient's drinking too much. I think the patient has gout. You're going to say, well, Mr. Pathologist, why do you think that? Well, when I looked on the microscope, under the microscope, I saw this negative polarized crystals. Wait, what? The negative polarized crystals is what I saw in the pathology report. Ah, why negative? Because positive crystals are more seen with calcium, and they're seen more with pseudogout. That's the reason why I'm telling you. That's how I know, because they're negatively polarized. It's gout. Oh, okay. So now I know. Uric acid, MSU, negative polarized crystals, the foot, All makes sense now. So if I have a exam question, I can go ahead and tease all these out. It will make sense. Well, can you show me a picture of what these look like in a microscope? Yes, right here. I'll send it to you, and this is what you'll see. This was on my boards, and that's the reason why I stole it from them, and I put them on here. I'm not sure if they're going to be on your boards or not, but if you see like a shooting star and those symptoms that I mentioned, boom, you're good to go. All right, so once again, uric acid levels, not during an acute attack. You get 24-hour urine, and it lets you know if uric acid levels are elevated. And then last but not least, you can also get something called serum protein electrophoresis. They're like those trap enzymes in the sense that it's very expensive to do. Insurance company's not going to pay for it. They're going to say, why should we pay $200 for this electrophoresis when you can do a uric acid levels, which is going to cost us $4? So insurance company is going to say, get uric acid levels. We're not paying for the SPEP. We're not doing it. Okay? This is what chronic looks like. This is what a toe looks like. You remember the case scenario I showed you before, where there's too much bone on top of bone? Well, this is exactly what's happening. There's a normal bone, and uric acid just got in there, these MSU crystals, and eventually deteriorated the joint. This is an unstable foot. This is more prone to fractures than a normal one. Meaning this one right here seems pretty normal. This one is abnormal, and this is a great toe. Okay, so last but not least, I'll get you guys out of here in 5 more minutes. How do you treat these patients? Well, medications like NSAIDs, non-steroidal anti-inflammatory medications. And you might say, what, like Motrin, like Bextra, like Vioxx, all that stuff you told us before? No. The one that we ultimately use for gout is a very unique one, and that very unique one is called indomethacin. It is a type of NSAID. When you hear gout, the first line of treatment for NSAIDs is indomethacin. Other forms of treatment are steroids, but a very short period of time, unless you want to do intra-articular steroids to bring down the inflammation. That might help. How often do we do that? Not so often. You're not going to stick needles in for gout. You just don't do that. Because the joints are unstable to begin with. You start putting needles within a joint that's already unstable, that has uric acid in it, you're just asking yourself for problems. So indomethacin might do it. Okay? Other forms of treatment are something called chemostasis inhibitors. And they work with inflammation within the body. And that medication is called colchicine. So your first line of treatment for an acute is either indomethacin or colchicine. Colchicine is given until the pain is completely gone. If it's not gone, then you stop until the patient has diarrhea. It's very strong in the stomach. There's a threshold of the GI gut. When that GI gut threshold breaks and the patient starts getting diarrhea, that means it's too much. At this point, you stop. And then one last one is for patients who have chronic gout. They keep on coming over to you and saying, hey, my big toe is swollen again. It just keeps on swelling up. Every month and a half, it's been swollen up. Not a problem at all. The way to approach allopurinol is, no problem, go home, take indomethacin or colchicine. When the pain completely stops, you come back and then have a third line of treatment for you. Well, yeah, what's that? It's a chronic medication that we use because at this point, you're chronic now because every month you're getting these. Well, what is that medication? That medication is called allopurinol. We don't give this medication for acute. We use indomethacin, colchicine, go home. When everything goes away, you're completely asymptomatic, you come back to me. I'm going to start you on allopurinol. But this allopurinol has to be taken daily. It will prevent additional flare-ups. You start off slowly and you work your way up. It's a great medication. It works. It just works, and it's very inexpensive. Well, let's talk about the ones that are not so cheap to get. They're the newest line of medications that are out there. And they're called probenecid, anturine, and so forth. These are other forms of medication. They work and they work very well. You won't see too many patients on them because it's still very expensive. But there is a contraindication. If you have any kind of kidney problems, if you have hereditary kidney stones and so forth, they are not treated for those patients. They're not meant for those patients. They work much like diuretics, but they're not. They specifically target the uric acid. And these, so they want to pull the uric acid right out of the body. But as they do so, they can make you dehydrated. If they make you dehydrated, then you have to do what? You have to drink a lot of fluids. A lot of fluids, a lot of fluids. Okay? Now these are the newest forms. At the current time, you probably see a lot of commercials out there for some of these medications, but they're not so much on the boards because they're fairly new. They've been only out for like 2 years. They might ask you this, but the only question that I've seen is, who do you not give these medications to? And it's usually treatment options, anybody who has kidney stones or any kind of AKI, chronic kidney disease. And it says, stay well hydrated. But once again, they're brand new ones. There's 2 more out there. I will update these slides and put those 2 ones on there. But once again, they're very expensive. Insurance companies will not pay for it right now unless you have really, really good insurance like NISHIP. If not, you're going to have to go back to alpurinol and things of that nature, which are dirt cheap. I think alpurinol is like maybe 11 cents a pill. It's dirt cheap. The new ones can be up to like $75, $80 a pill. Yes.
Do we need to know the dosage for
No.
any? No.
You don't need to know this. Right? So we'll come back to pseudo